Minnesota has been working on these issues for many years and decades, and along the way, I think, has learned some important lessons that we hope will inform the national debate. Minnesota has a very strong interest in these issues because what happens in Washington, D.C. is going to affect what happens in our state and to our citizens and to all states across the country. And we have some reflections and some ideas and some suggestions and lessons learned to share. We thought it would be timely to do that today because Minnesota will be in the spotlight as the president comes on Saturday. We certainly welcome his visit to the state of Minnesota and hope that his remarks here will be informed by the Minnesota experience and that the items that we share today will be helpful in helping him understand both the successes of Minnesota's healthcare reform efforts as well as some of the remaining challenges and opportunities. Let me first start by saying that I think it's fair to say that Minnesota has led the nation in healthcare reform in many respects. Very proud of my administration's record in this regard in the last 7 or so years. I think we've been viewed as one of the most aggressive and impactful states when it comes to reform and change and improvement in healthcare. But our view of that is that it needs to be less government-centric and more consumer-centric and more purchaser-centric. And there's just an honest difference of opinion about which direction to go in that regard. That difference of opinion certainly exists amongst the Minnesota policymaking community. And here at the legislature, we have people who view a more government-centric, government takeover kind of model as the right way to go. That's not my view. That's certainly not the view of my administration. We have a more consumer-centric and market-centric approach to these issues. But nonetheless, this is a debate that needs to be resolved, and we need to make some progress because the current system is financially and medically and otherwise unsustainable. So here are some of the lessons. These are certainly not all of the things that we'd like to share with the president and to the policymakers nationally and here in Minnesota, but some of the things that we think will inform the debate as it continues to unfold. Number one, and these are the kind of in the nature of a top 10 list that Minnesota has learned in this arena. Number one, we can't afford what we already have. If you look at the cost structures in Minnesota of the publicly subsidized health care systems that we have, they are growing at an unsustainable rate. They are growing at a rate that we cannot currently reasonably pay for, and that situation is accelerating and worsening by the year and will only get more difficult and more problematic going forward. So as we look to models for providing assistance to people who are not able to fully afford their health care or their health insurance themselves, we need to be careful about embracing models as they currently exist in the publicly subsidized health care models in Minnesota. A couple of examples of that are the Minnesota Care Program, which again is a well-intentioned and in some ways impactful and effective program. From a cost standpoint, though, it is growing at an unsustainable rate. We have increases in the expenditures for the Minnesota Care Program in the last 2-year budget at 34.5%, at a time when the state's general fund budget, in other words, the spending on other things that are also important, went down 7.6%. And in the premium area, the amount that this costs for premiums each year, the average increase has been almost 12%. Over the last 10 or so years. So that is not a model of cost containment and affordability that would serve the nation or serve Minnesota well going forward. Number two, we recognize and encourage the president and members of the Congress and members of our legislature to move from a system, continue to move from a system of paying for volumes of procedures to paying for value and paying for better health and better health care outcomes. The money that we pay for now is based on the frequency and volume and number of procedures performed by healthcare providers. That is not a optimal way to pay for things. If you pay for volumes of procedures, you're going to get more procedures. We want to pay for better health, better healthcare outcomes. I think it's fair to say that Minnesota has been the nation's leader, certainly one of the nation's leader, in beginning the transition from the old outdated payment systems to the type of payment system that I'm describing. Number three, we need to focus on cost and quality as much as we do expanding access. The system that we have now has about 30 to 45 million Americans uninsured. Minnesota, however, is substantially above that. We have about 92% or so of our citizens insured. That's the second highest percentage of individuals insured in the nation. expanding access to insurance is really important, but it's not more important than making sure that the 92% of our citizens who have insurance can afford it. So we need to be equally focused on containing costs for those who are insured as we are to just expanding access. And if you expand access to a broken system, you really haven't fixed anything. So the President and others talk a lot about cost containment and costs being out of control, but if you look at the heart of many of their proposals, it's more about expanding access than it is about containing costs. And those numbers and statements are verified by the cost increase projections by the nonpartisan Congressional Budget Office. Number 4, we think the country and our states and our individual citizens need to have much more access to health savings accounts and consumer-oriented, consumer-driven, consumer-empowered health care plans. Minnesota has the highest concentration of individuals who have a health savings account or similar styled account in the country. These are like 401ks for health care. About 9.2% of our population is participating in that kind of account, and the savings realized by these plans are real, measurable, and meaningful. And it also puts consumers in charge. And they're not appropriate for everyone because we have some individuals, because of disability or other limited situations, that they need to have other kinds of plans. But this needs to be an offering that's available to all or most of our citizens, or as many as possible. Number 5, we need to enact tort reform. The President last night opened up the door to at least a discussion about this topic. We know that medical malpractice, another fancy term for the fear of doctors getting sued, or in many cases being sued, is driving unnecessary amounts of tests and other procedures. This is verified by a recent Harvard University study and many other studies that preceded it, but that study concluded that about 30% of all the health care in the United States is medically unnecessary. And the reason that it's medically unnecessary is primarily driven by fear of lawsuits, in other words, doctors being sued for malpractice, or the excess capacity or empty capacity of the providers driving the decision-making as compared to the actual medical needs of the patient. But as it relates to medical malpractice reform, we need to reduce the fear that doctors have to such a degree that they are wildly over ordering tests and diagnostic measurements. At the state fair, I had many healthcare providers just privately admit this. I shared the conclusions of the Harvard study with a couple of doctors, in one case an OBGYN, and she said 30% would be an understatement, that she does much of her practice around concerns about being sued and the costs and consequences that come with that. So some reasonable steps in that regard are these. We would encourage the President and other states to consider what Minnesota has done, and that is if somebody wants to sue a doctor or a medical provider for malpractice, they should be required to have another doctor in good standing in that state file an affidavit to say that it looks like there's at least probable cause to conclude that malpractice occurred before the lawsuit is filed, or at least as the lawsuit is being filed. Minnesota requires that, along with a small number of other states. It seems to have a positive impact on keeping our medical malpractice premiums more reasonable here than they are in other parts of the country. And we also think that it would be reasonable to place some reasonable caps on the non-economic or non-compensatory damages that come with these kinds of lawsuits. We're not saying they have to be zero, but some reasonable limit on those kinds of damages we think would help to the overall issue. Number 6, provide consumers with more information. I think many of you were at our press conference a few weeks ago where we unveiled a first-in-the-nation initiative to publish on a website the average price charge for the most frequent or top 100 procedures in the state of Minnesota. This will be part of an overall movement that will be very powerful. Once people realize what other people are being charged, payers, purchasers in the marketplace can begin to benchmark against that as they negotiate prices and procedures. Digressing from this a little bit, we're also seeing some very exciting pilot projects and experiments around the country where we might be able to even aggregate needed procedures by volume and then have them put out in a bid format across the country. So for example, if the Mayo Clinic has the capacity, excess capacity in a given month to do more knee replacement surgeries because for whatever reason their patient load is down that month, they might be able to offer some special pricing to people or providers or insurance groups or risk pools that say have a backlog of 100 needed or 200 needed knee replacement surgeries. And there's been some efforts to test this, and they were able to reduce the price of those surgeries in the neighborhood of 50 to 70%. Remarkable effort. Next, number 7, use market principles to hold costs down. We hold out the Minnesota State Employee Program as just one example of this. And again, this is in a fairly primitive form, and it's going to get even better as the data and systems get even better around this. But in conjunction with the unions that are representing the state employees, the employer, in this case it just happens to be the state, but it could be any employer, said, look, these costs are unsustainable. They are reckless. They are ruining the financial stability of the employees and their families, as well as many businesses. Again, in this case, the employer is the state of Minnesota. So we had the flexibility to enter into negotiations with the union and customize a healthcare delivery system and plan called the Minnesota Advantage Plan that met the needs of the employer and the employees. But it featured this important thing. It said, as a principle to the employees, you can choose where you'd like to go. But if you choose to go to a high-cost place with poor results, you're going to pay more. And if you choose to go to a low-cost place, a high-cost place with poor results, you'll pay more. If you choose to go to a place that has low quality and high cost, I've got that backwards. We start over. If you choose to go to a place with good results and good efficiency, you'll pay less. If you choose to go to a place with bad results that is inefficient, you'll pay more. They are voting with their feet and their wallets, and they're migrating to clinics and providers that tend to be more efficient, tend to have better healthcare results. There's high levels of satisfaction with the employees. Their healthcare quality has been maintained or improved as measured by utilization and measures of health. But importantly, the cost containment has been powerful. Even on those just primitive measurements, 3 of the last 5 years, the premium costs or the employer costs for their health insurance has been 0%, and the other 2 years of that 5-year period, it's been substantially below market. So that tells you the power of giving people good information and incentives to make wise healthcare decisions, but also to incentivize them financially to do so. Next, number 8, engage the private sector as a partner, not as an opponent. Within the private sector, there are creative minds, there are strong leaders, there are reform-minded people who are purchasing health insurance for a wide section of the country and the states across the country. Through the Purchasing Alliance, Smart Buy Purchasing Alliance, we've been able to partner with them on a voluntary basis to drive changes through marketplace principles. For example, setting up measurements around healthcare quality, starting to align payments to that quality, and then approaching the marketplace again, on a voluntary private market basis and saying, this is what we expect if we're going to buy health insurance from you. We expect these kinds of capabilities, these kinds of systems in place. Number 9, require that medical errors be reported and don't pay for them. Medicine until recently, and in Minnesota was the first state to do this, if people make mistakes and don't deliver what they're supposed to deliver, you shouldn't have to pay for it, and that just makes common sense. And then lastly, this isn't so much a Minnesota statement as it is things that we think would be helpful. And many of this we think could be agreed upon on a bipartisan basis, but we should prohibit or limit the ability of insurance companies to deny insurance based on pre-existing healthcare conditions. You shouldn't be denied insurance because you've been sick in the past. Now, there needs to be a reasonable waiting period around this because you can't just not have insurance and then wait until you get sick and then go buy it the next day. There's got to be some fairness around that kind of situation, but we would certainly encourage and agree to that principle. We also think in the world that we live in today, it is ludicrous to not be able to buy your health insurance any place that you'd like. I mean, we want to open up markets. We want to open up choice. We want to open up variety. We want to increase competition, and it's extremely stifling to consumers and patients and purchasers in Minnesota to essentially have only 3 choices in the private market. We essentially have 3 payers in Minnesota that dominate the market to the tune of 80+% of the market share, and that is limited. Frankly, it is, in my view, semi-monopolized. And we should be able, in the world of the internet, to go on with appropriate consumer protections and buy insurance in Iowa or Wisconsin or California or New York, have many more choices, many more options, and allow the marketplace to bring more competition to work and to bear in these kinds of considerations. The same with pooling risk across state lines. If we have a group of interested citizens here who want to associate with a group of citizens in another state, there shouldn't be artificial limits on or boundaries around how and where we can do that. Again, it is a marketplace opening principle, and these closed markets within states are relics of bygone eras with bygone economies and bygone technology, and clearly we could benefit from more competition, more choices, more options by opening this up, again, within the guardrails of appropriate consumer protections. So these things we think would all help. Again, we welcome the President to come to Minnesota. This is an important debate. There are honest disagreements about how to best deal with this issue, but there's not a disagreement about the fact that the healthcare crisis needs to be addressed. I define it mostly as a cost crisis. The current administration and Congress is defining it mostly as increasing costs and access issues. Again, both are important, but the main crisis for most Americans and most Minnesotans is it needs to be more affordable. With that, I'll invite the commissioners to make some brief comments, and then we'll take your questions.
One of the hallmarks of Minnesota in its health reform is that we've actually established goals, and that we want to improve the patient experience, improve population health, and improve affordability. We need to do all three as we move forward. One of the hallmarks of what we're doing is we are exposing, shining a light on quality and cost. You can't have a market, you can't have people able to choose, able to make choices if they don't have information. And we are providing that in Minnesota. As you saw examples most recently with information around price, it exposes the wide variation in price. We are going to be able, and Minnesota Community Measurement has also exposed the wide variation in quality. In just a year's time, we will be able to expose the wide variation in value when you put quality and cost together. So we believe that Minnesota has an opportunity, with help from the federal government, to continue to be more innovative. And we would ask that states would be allowed to be laboratories for innovation, to continue to provide the kind of care that Minnesotans expect, and to focus on improving population health, improving the patient experience, and improving affordability of care.
Thanks, Doug. Yeah.
It's my belief that there's probably 20 or 30 other initiatives that have taken place in the last 5 or 6 years in Minnesota that are unique to the nation, and it doesn't make a top 10 list, but we can certainly add more to this list. For example, our public-private partnership with the Health Information Exchange, which is fulfilling this promise of interoperability health records, and a lot of electronic technology that is taking place and accelerating its use in Minnesota that is not taking place in many other states. The other missed issue here, I think, that is not talked about either last night or in the last 3 months in Washington, D.C., is how Medicare itself could participate in some of these reforms, even within a state market. For 15% of the market to be off the table, and for providers to somehow create enough critical mass of payers to pay more uniformly or better for this kind of payment reform idea is a hard thing to pull off. For some hospital systems in Minnesota, the Medicare portion of their revenue stream is 40, 50, and even 60%. So without that kind of participation for Medicare, if Congress could not deny any senior citizen any access or coverage or high benefit plan, but think about a different payment model or participation in a state market the same way, you would see a lot even accelerated performance on this. But little attention is given to the Medicare portion of this debate.
A couple other miscellaneous thoughts. Of course, one aspect of the federal reform is potentially dealing with the Medicaid program. We have an important partnership with the federal government around Medicaid, what the eligibility requirements are, who pays for what share of it. Under one of the leading proposals in the Democratic-controlled Congress, there would be a mandate that states require to cover childless adults, in other words, adults without children, up to 130+%, maybe up to 300% or more of poverty, with the potential for the state having to pay for a very significant portion of that. That would be extremely challenging to the states in terms of their budgets and financial abilities. There's been a couple proposals to say the feds would just pay for it all, but obviously they don't even have the money to pay for what they're doing now, much less adding stuff to the pile. And then beyond the publicly subsidized programs, if you just look at the private market premiums in Minnesota, for the years that are most recently available, and this isn't in the paperwork, one year of 2006, whereas the data was most recently available, our private market insurance premiums went up a little less quickly than the national average. You'll see in a few weeks or months, I'm not sure when the new report comes out, that will be slightly higher than the national average, so they bounce around from year to year. But if you look at it over say, since 2000 until present, Minnesota's premiums are, on average, on a rolling average, a little lower than the nation. Now, there's a lot of different reasons for that, and if you zero in on just those states that are more comparable to Minnesota, say Wisconsin and, Indiana and Michigan and places like that, it gives you a little different picture that we're not really that much lower. So the premiums are a little lower in Minnesota, but again, there's lots of reasons for that, and they bounce around from year to year. So with that, we'll be happy to take your questions.
Governor, regarding the ending of the crossing state lines to access insurance, this small group, part of it created ICSI, which created some of the things that have put Minnesota ahead. They were also part of measurement, which is obviously something that's put Minnesota ahead. And that was done with that small group. If you break that up and have an open market, it will be harder to do some of those reforms that can work better in a small partnership with the top that are.
The premise is, wouldn't it be easier to do these good and important things with the few local people than 100 or 200 national entities? Yeah. And I would suggest to you there's certainly been a helpful partnership in Minnesota on things like ICSI, on things like community measurement, but the power of opening up choices for consumers to not just 3 choices, but 300 choices, I think would be remarkable. If you look, for example, at Clayton Christensen's work about change in education or change in healthcare, decentralization is a big part of that. In other words, creating the tools and the power and the resources for lots of different decision makers to make different choices and have choice in a marketplace is what drives change. And we have a very cloistered, very narrow, semi-monopolized healthcare marketplace in Minnesota and, frankly, in many other parts of the country that I think we would benefit from opening it up. The market is moving towards pay for performance and some of these other things anyhow. So in order to compete, you'd have to be improving. And I think the fact that some of your competitors might be doing it quicker, faster, better than you would give you incentive. I mean, we appreciate our health plans in Minnesota. They have been good and faithful partners. But in the year 2009, the idea that our citizens can't get on the internet and with a click of a mouse shop for insurance in Wisconsin or Iowa or anywhere else that they feel like is ludicrous. I mean, it's like living in the 1930s.
Why can't they do
that? The law prohibits it.
State law?
That's state law, yeah, and federal law.
Change it?
I would love to change it.
Have you submitted a proposal to change it?
Well, I've been calling for change to do that, including these. I think the legislature has not yet been supportive of that, but we hope that they'd reconsider it.
On the pay for performance, they are paying for better quality. How far is that happening now? Is the state doing that?
Sort of. Martika, and I'll have the commissioners comment on it as well. But if you look at the Bridges to Excellence program in the areas of diabetes and now heart disease, right? Is there a third one?
Depression.
And depression. We are paying bonuses to providers for optimal care. Now, in the intermediate term, optimal care is a set of standards and treatment protocols. It is an intermediary step between what we have now and measuring healthcare outcomes. So we're paying for providers following optimal care protocols. Those protocols are likely, we believe, to lead to better health, but we hope soon that can be replaced by actually paying directly for better healthcare outcomes and or what's called either episodes of care or baskets of care. So you have people, for example, working at the Fairview Clinic in Eagan to identify the most frequent common procedures. And let's say it's a knee injury. Let's say you tear your a meniscus in your knee and you need to have arthroscopic surgery around your knee and all of the likely attendant items that go with that. They want to bid that out at one price. Offer it, first of all, define what it is, put a list of what it is, and then assign a price to it, and then market it, that basket of services or episode of care, start to finish, for a price. And that would be then put in the marketplace, and others could measure against it and compete against it. So that's what's next, and I think beyond that then would also be the, making sure that it actually worked, that we would pay for the healthcare outcome we desire, which isn't just the operation, it is your knee works again.
And how far off is that?
I think you will see, first of all, we have currently Bridges to Excellence pain bonuses for best practices and treatment protocols. I think you will see in the Minnesota marketplace, and we may be the first in the nation to get there, baskets of care and episodes of care being defined and offered as early next year.
And what about paying for better quality? Is that the same thing, or is that something different?
That's similar but not exactly the same thing. And as to quality outcomes, I have to be candid, nobody has actually done that yet. We are using as a proxy for quality outcomes treatment protocols, soon to be episodes or baskets of care, but associated with that would be the care actually works and the health is restored, improved, and the like.
Did the president make any headway last night in drawing bipartisanship or getting something?
Well, it doesn't seem like it, Eric, because it seemed to be largely just a recitation of what he had said before, with one exception, and that is he had taken off the table any discussion around lawsuit abuse reform, and he at least opened the door to that last night, ever so slightly, because he described it as the possibility for some pilot projects, but at least it's back in the discussion. So it appeared to be largely a summary of what he had said before.
The president didn't mention Medicare inequities, and the system of appeal has high quality care at lower cost. Do you know whether that's in any of the plans?
It's talked about a lot, Bill, and there was some semblance of it in a few of the amendments to one or two of the plans. And Congresswoman McCollum, for example, I think had some success in getting an amendment offered in the House to one of the plans. Whether that remains in the final package, certainly Minnesota would benefit from that. We get punished significantly because the Medicare reimbursement system is based on historical cost measurements. Our historical costs compared to other states are lower, so our reimbursement rates are lower, which means the providers here get paid less by Medicare, by the federal government for the exact same procedure that other providers in other states get paid more for. Every member of Congress that we've elected to Washington, D.C. to represent us for 50 years, 40 years has said, I'm going to go fix that. They never do. The big states are against it. And I would guess one thing we could constructively challenge the president and the current majority in the Congress is, if you're serious about reforming this, that is a naked, indefensible inequity that should be included in the reform package. Will you include it? And I would hope the answer is yes.
Governor, a lot of people are analyzing the heck last night as proof that civility wagon has fallen off the cliff and we can't discuss things as rational, civilized people anymore.
You're talking about the member of Congress who
Yes.
yelled out your line? Yeah. No, that and unfortunate, and he shouldn't have said that. When you have the President of the United States addressing a joint session of Congress, there's a degree of decorum and respect that should be afforded the office and the person holding the office. Applause is appropriate, silence is appropriate, but in that setting, heckling is not.
Would that apply to his speech to the school students this week?
I don't think anybody heckled him.
No, what I mean is that should respect for his office imply that people shouldn't challenge his right to talk to kids?
Yeah, my main concern, and I think others' main concern, was reflective of the concerns expressed by the Minnesota Association of School Administrators. It's not a partisan statement. They were concerned as school administrators on the first day of school with children trying to find their classes, confusion about bus schedules, books, orientation, on that particular day to gather up the students, listen to the president for 20 minutes, get the equipment, could potentially be disruptive. So I think that was a fair concern. But I think the president handled it nicely. He conveyed an important message. It was not political. It wasn't partisan. So I think in the end, he handled it nicely.
Was that speech shown in your children's school?
It was.
And did you have any objection to that?
No. My daughter, my younger daughter for sure saw it, and I think my older daughter did as well, and I had no problem with that.
And then today, and you had before, you talked about cost versus access as the goal. Is there an appropriate level of access to health care? Should there be any uninsured? Is universal coverage your goal?
Well, we have, it's a complex question, Rachel, but ideally we want to have as many people as possible covered. But even Massachusetts, with an insurance mandate and a penalty and all the other features of their program, did not achieve 100%. They still have several percent, and it fluctuates, who are uninsured at any moment in time. Now, these numbers vary depending on which source you go to, but as a general proposition, we have 30 to 45 million Americans who are uninsured. Many of them are uninsured for just a little while, some longer. It's estimated that about a quarter of the individuals are here illegally. We also have the phenomena that we've got about 25% of them are actually eligible for an existing program but don't take advantage of it. And so you've got 50% who either wouldn't qualify or are already eligible, but for one reason or another, have a barrier to get the forms filled out or get the access, and that could be, I think, fairly simply addressed. So you've got the number down more reasonably. But, again, even in Massachusetts, which is viewed by this administration, I think, as a model, much of what they're doing is similar to what's going on in Massachusetts, they still have several percent uninsured.
So is Minnesota now, I think, has 8.7% uninsured according to the census today. Is that acceptable, or should there be fewer?
Well, I think it's the second highest rate of insurance in the country. So relative to the rest of the nation, we're doing pretty well. And we still can and should do better, Rachel. But all I'm trying to convey is, if you have as your only goal or your main priority expanding access, and all you're doing is expanding access to a broken system that is bankrupt or will soon be bankrupt, you have not solved the problem or meaningfully addressed it. And we have to do both. And I'm just suggesting that the emphasis that the current administration and Congress is placing on access is coming at the cost of them seemingly neglecting cost concerns. Again, this is not a partisan statement, but the Congressional Budget Office estimates that the main proposals, are going to cost approaching $1 trillion of additional money. So they are basically spending more. Say that again? 10 years. Over 10 years, yeah, that's fair. Yes, over 10 years. Thank you. So they're spending more to contain costs. That makes no sense. It's like saying we're going to write more checks to balance the checkbook, and they have no way to pay for it. They have refused to identify how they're going to pay for it. So if you add up the things that are clear in the bill, maybe covers 25% or a third of it, and the rest is going to be claimed in the form of unspecified cost savings and fraud, waste, and abuse, particularly in Medicare. And I don't think that we should transform the entire healthcare system around that promise, because I don't believe it.
Governor, take some questions.
Okay, yeah.
This is mostly just focused on cost stuff, isn't it? All these 10 principles are focused on cost.
Yeah, and again, in my way of thinking, all three of those goals are important, Tom: access, quality, and cost. But for most Americans and most Minnesotans, if you had to rank order them, it's cost. The current system is unaffordable. Their prices are going up too fast and too high. That isn't to say the other things aren't also important, but if you're going to set priorities and focus on things, the cost crisis should get as much or more attention than the other two considerations. We'll come back in the room if you have time. We'll just take a few calls from the phone in the meantime. Operator, if there's some questions on the phone, you can go ahead and open it up. Operator?
If you would like to ask a question, please press star then one. I'm showing no questions at this time.
All right, if any come on, let us know. Otherwise, we'll take a few more in the room if there are any.
Governor, the president last night said he would call out anybody who distorted the debate on health care, put out lies. Are you willing to do the same thing?
Call out people?
Call out people if they're putting out false information, perhaps in your own party or the DFL
You know, it's not helpful to the debate if people are intentionally putting out false or incorrect information. So, you know, there's honest differences of opinion about which direction to go, what philosophy to embrace, but it's not helpful if people are manufacturing or fabricating things.
But would you call them out on something like that?
Well, I certainly think we should make sure the record is correct and accurate, yes.
Would you call them out?
What do you mean by calling them out?
Would you give them, would you somehow make comment or bring attention that they are misstating the facts?
I think if I knew that somebody was misstating the facts, I would point that out, yes.
Okay.
On the 30% procedures may be unnecessary, which we've heard over and over again. And that's got to be a major part of your interest in cost. But if you, or let's say the president, tried to do anything about that, you'd be run out of town accused of rationing. I mean, we seem to be in a complete bind where you cannot crack down on unnecessary procedures because you're accused of death panel, rationing, etc. How do we get out of it?
Well, Jim, I think the way to address that is, first of all, it is not my claim. I believe it because the Harvard study stated it, and similar studies have also stated it. So I think it is meritorious as a point to consider in this debate. It is not rationing to say that we are going to discourage frivolous lawsuits that scare doctors into ordering stuff that's medically unnecessary. You know, if it's medically unnecessary and it's not needed, it's not a form of rationing, and the doctors admit it. I mean, you talk to doctors privately, they'll just tell you, yeah, especially in certain specialties. As to the issue of capacity, you know, driving the decision-making as opposed to the medical needs of the patient, I think that can be solved by allowing the patients to make these decisions. I mean, the model that is being pushed in Washington moves decision-making, or at least elements of it, into the federal government. And the fear that people have is, first of all, we can't afford it. It's breaking the bank. As it continues to break the bank, they're going to have to dial back on stuff. As they dial back on stuff, it's going to lead to rationing. We're going to end up with situations like they do in the United Kingdom, where you got either wait lists or treatment denials for certain things, and in other countries like that. And it scares people for understandable reasons. So I would say, put the consumers in charge. Give Jim Ragsdale or Bill Salisbury the allotment of money that either your employer or your family or you or the government can provide to you in the form of a voucher, a credit, the allotment amount of money that we can afford as a state or a nation to give to you. Put some consumer protections around making sure you know there are good products in the market, and then let you decide. And you can decide how to allocate the resources, you know, in most instances. Yeah, go ahead. Yeah, Sanne, go ahead. Go ahead.
I would just say, I mean, one of the things about Minnesota and our local environment, this blend of collaboration and competition, is that providers have gotten around the table at places like ICSI, Minnesota Community Measurement, and said, what's going on with rising high-tech diagnostic imaging? And they design decision support that's right there in the office when the patient and the doctor are there, and they can look at, you know, based on the best practices, do you need another MRI? You know, do you need a CT scan done? And that's not rationing. That's making good, wise medical decisions in this environment in which we have collaboration, where doctors and health plans and people come together and say, what's best practice, and let's drive out that excess waste. I mean, a classic example is urinary tract infections. Used to be if a woman had one, she had to go into the doctor, pee in a cup, wait, get this. Now that's all handled over the phone. And it was the providers and consumers who came together and said, let's find a better way, take out the waste, more convenient, better care, better quality, and less cost.
We do one last question here.
Could you have that kind of collaboration if the governor wants anyone to buy health care from any state or any country all over the world? Could you have that kind of collaboration?
You know, I don't know. I think trying to find the right blend of collaboration and competition, and I think we've done a good job in Minnesota. Can it be improved? Of course, we can always look at improvements for how to do that.
Governor, can I just clarify one thing?
Sure, Tim.
You mentioned moving more towards the consumer model system. Are you saying that you should move away from the traditional employee-sponsored
health system that's there now where, you know, a pool of folks get together, a business gets together, whether it's a large business and goes into a health insurance system? Are you saying, let's go and just give an employee $1,000, $2,000 and you're on your own?
Yeah. No, Tom, I think, you know, if we were starting from scratch and we were inventing the system anew, you would probably have it be just all individual based and provide assistance to the individual through the tax code, through cash grants or otherwise. But that's not realistic now. And so we have a system of employer-based insurance. That's the one we have to work on and improve, and that's the way it's going to remain. So within that, though, we have to have more consumer empowerment, and frankly, we have to worry about what this looks like going forward. The U.S. Department of Labor now says that the average person between their teenage years and the age of 40 is going to have something like 30 different jobs. So if we have your insurance dependent upon whether you continue to have it or not based on whether you switch jobs or not in such a dynamic, changing, evolving economy, it puts people at great risk. So one aspect of this is something called portability, which means you might get insurance with one particular job that you like, and you have the ability to carry it forward beyond just ERISA, beyond, or COBRA, I mean, that you have the ability to carry it forward from job to job. So we have an employer-based system for a big part of the economy. That's what we have to build upon and improve. But where we don't have employer-sponsored insurance, we should encourage individuals to go into the marketplace with financial assistance if they need it through HSAs and other similar style programs. I think that's a big part of the marketplace for those who don't have employer-based insurance. And it's a big philosophical dispute. I mean, to be very blunt about it, we've asked the Minnesota legislature in programs like Minnesota Care to offer a private market option for people if they want to choose it rather than just getting the off-the-shelf, you know, government-directed version. Can we have a choice, not a forced choice, but a consumer option? And philosophically, the Democrats don't support that. They want the government to run all this stuff, and that doesn't, it's not my view of the future.
Thanks, guys.
All right, thank you, everybody.